Thank you very much to everyone here today for joining this webinar. This is a pre-summit webinar, our summit being the Patients Redefining the Future of Healthcare in Canada Summit. And this particular webinar is a review of the complex health systems that we have in Canada that are impacting our journey through these systems, and particularly as it relates to the approval of drugs. As we gather virtually today, we acknowledge that we are meeting on the traditional lands of Indigenous peoples across what is now known as Canada. This land has been home to diverse First Nations, Inuit, and Métis communities for thousands of years. We honor their longstanding relationships with these territories, which continue to this day. We recognize the ongoing stewardship of the land by Indigenous people and the importance of acknowledging the histories, cultures, and contributions of the original caretakers of these lands. We invite everyone to reflect on the land they are joining from and to engage in our collective journey of reconciliation. So as this pictogram indicates, there are a number of systems that have quite a bit of impact on the availability of patient access to healthcare and particularly to access to medications. So some of them are federal, particularly the Health Canada and the Patented Medicine Prices Review Board. Some are a joint venture between the provinces and the federal government, which include all the provinces except Quebec. For Quebec is done through INES, and it's a health technology assessment to determine whether there is value to the drug for the public reimbursers. If they decide that there is, then they send a recommendation to what is called the Pan-Canadian Pharmaceutical Alliance, which is an alliance of all the provinces at which they negotiate the price of a drug that they're prepared to pay for public reimbursement. Then it goes down to the provinces and territories to make the final decision about adding this drug to their list of drugs for public reimbursement. In addition to this, of course, some people have private plans, which may provide more coverage, and hospitals have their own list of medications. So the other thing I wanted to mention, although it's not directly related to this presentation, is the Canadian Institutes for Health Information, CIHI, which is also a federal agency, and it's been mandated to help the federal government create a pan-Canadian data management strategy, with of course the alliance with the provinces to do this. You'll be hearing a lot more about that, I think, as time goes on, because it's become very clear that without proper data about people's health and their health situation, we do not know really enough to make the best decisions we can on an individual basis, or in fact, at a systems level for policy. So let's get a little deeper into the federal government's role. The main role that it has, perhaps one of the most important, is that it ensures universal access to doctors and hospitals, but not drugs, under the Canada Health Act. There's often a misconception that this does include drugs, but in fact it does not. It also ensures non-excessive drug pricing practices in Canada through the Patented Medicine Prices Review Board. This is an independent, separate agency of the federal government. The federal government also provides some transfer payments for health to the provinces. And the provinces also provide funding for health, but the federal government is certainly a partner in the payment for these medications from that perspective. So, as I mentioned, the federal government reports and analyzes health data that it has collected, and it approves clinical trials to ensure that they're safe, effective, and good quality treatments, medical devices, over-the-counter drugs for sale in Canada, and post-marketing, including the ability to remove a drug from sale if required. Also, I'm not going to get into this at all today, but just so that you're aware, there is at the federal level also a rare disease strategy. It's a framework that provides funding to pay for rare disease medications. And recently, the federal government also passed pharmacare legislation that provides funding to the provinces to provide first dollar coverage for contraceptives and diabetes drugs and devices. And of course, provincial agreements are required in order for both of these programs really to go forward. Once the federal government has made the decision through Health Canada that a drug is safe and effective for sale in Canada, the next question is, will the provinces and territories, and in some cases even the federal government, reimburse for this particular drug? So this is done by asking the question, does the drug have value for public reimbursement plans? And they have multidisciplinary processes that summarize information about the medical, social, economic, and ethical issues related to the use of a health technology. There are four main criteria that the Canada Drug Agency, which is the health technology body for the 9 provinces except Quebec, and INESS, which is the Health Technology Assessment Agency for Quebec, what they consider are these four main criteria. And what they're looking for is clinical data. Does the drug work? How does it compare to other currently available medicines? Economic data, the cost effectiveness of the drug, the budget impact, patient impact, particularly on quality of life, could be side effect management, it could be mode of administration, and how does it fit into the system? So in other words, will it be a major disruption to our health system to integrate this particular drug into the system? So the only difference between the two systems is that INESS also includes societal value when making its decision. And the Canada Drug Agency has not in the past done that, although it's definitely considering doing so now. So they're gathering information to make this recommendation to the provinces through these particular criteria, and they provide then a recommendation to the provinces about whether to consider the drug for reimbursement. And this is a collaborative effort between the federal, provincial, and territorial governments. After health technology assessments are evaluated, there is a recommendation made by the Health Technology Assessment Agency. They have different types of recommendations. One is simply not to reimburse the drug because it does not have benefits and it's not better and or costs more than what is currently available. To reimburse, the drug should be listed because it's effective and the price is lower or similar to what is currently being paid. That's a rare decision. The most likely decision is a reimbursement recommendation with conditions. And so what that means is that the health technology assessment body believes the drug is clinically valuable, but the price may be too high for the provinces, and the manufacturers need to negotiate a lower price if in fact they wish the drug to be reimbursed. So then who makes the decision then about the price? This goes to another federal, provincial, and territorial organization called the Pan-Canadian Pharmaceutical Alliance. It's a coalition, as I've said, of all the provinces, including Quebec. It's a creature of the Council of the Federation. For a long time, it had no legal status, but it recently has become a standalone, not-for-profit organization, giving it status to do negotiations on its own and to make decisions on its own. So the price is usually the main issue to be negotiated, and negotiations are between the PCPA and the drug manufacturer to lower the price for the provinces. One province agrees to lead negotiations for all. Provinces opt in or out of the process. Even provinces agreeing to the price do not necessarily commit to adding the drug to their public reimbursement plans or to accept the negotiated price. Once negotiations are complete and conditions have been agreed to, a letter of intent, an LOI, is issued stating at what price and under what conditions the drug can be reimbursed. There is no opportunity for stakeholder input for the negotiation of these agreements, and the final agreement is confidential. We know that in 2020, 78% of oncology drugs required between a 50 to 100% price reduction based on the Canada Drug Agency reviews. So once there's been a negotiation of the price by all of the provinces and the federal government, the provinces each independently make a final decision about drug reimbursement, when they will reimburse and under what conditions they will reimburse. And this is the reason why we have such a patchwork quilt, just as it's often called, of our drug coverage across the country. Many drugs are delayed at this level for long periods of time, or in fact are never covered by certain provinces. There is no formal stakeholder input process at this stage, but there are opportunities for input to be considered in some cases. People required to pay copays and deductibles often do not fill their prescriptions, and even if they are eligible for an approved treatment, they'll skip doses or forgo necessities to pay for them if they're covered at all. So this is definitely not universal access to drug coverage for people, even though it may appear to be on its face. So just a recap. The pharmaceutical company does the clinical trials and it submits information to Health Canada. Health Canada assesses the safety and efficacy of the drug and issues what they call an NOC, a notice of compliance, sometimes with conditions. Then the health technology assessment bodies, both the NES and the Canada Drug Agency, makes an assessment of the value of the drug to the people and the system, and therefore making a recommendation that it should be reimbursed at the public plan level. Then the drugs go to the PCPA, and the PCPA and the manufacturer negotiate a price. Individual provinces then make final funding decisions. There, as I mentioned earlier, there is a private payer landscape as well, where additional coverage for drugs may be possible if your employer, for instance, or your union, or even you individually have purchased a private plan. But there are lots of conditions on these plans, and people often don't realize that they often put caps on the amount that they're willing to cover of dispensing fees in for any drug. They favor drugs that are most cost effective. They can often have a yearly maximum or a lifetime maximum, and they prefer to reimburse often only to the generic price, which will be less than the brand name price. So that's the system that we have. And just before we leave, I want to go back to the point that I made earlier about people being in the system theoretically and not necessarily in the system. There are, and these are often impacted by what are called social determinants of health. A social determinant of health is something outside of your specific health problem that impacts your health outcome. And some of those things are individual and some of them are systemic. So, for instance, there may be, due to race, biology, and genetic endowment or culture, and sometimes as age and sex and constitutional factors may affect how well you are able to get a good health outcome from a drug. So that's an individual lifestyle. Then there are individual lifestyle choices. Childhood experiences, healthy behaviors, coping skills, culture, they may all impact your ability to engage with the healthcare system in a way that will give you good health outcomes. In addition to which, the ability to be engaged with social support systems and cultural support systems may have a very positive or negative impact on whether you do well in terms of health outcomes. Then on a much broader scale, the ability to have access to education, the work environment in which you live, water and sanitation, what healthcare services are actually available, your income, your housing, your living and working conditions, all of these can also have a direct impact on the value of the health outcome that you get from a particular health treatment. And last but not least is general socioeconomic, cultural, and environmental conditions. And those are often impacted by racism, physical environments, and culture. So it's not as simple as a drug gets through a drug system, and our drug system isn't simple to begin with, but even where a drug theoretically is available to people through a public reimbursement system, there are many factors outside the actual reimbursement system itself that make it difficult for people to access the system or to be able to manage the system and coordinate through the system in order to have a healthy outcome. Another way of looking at it is that social determinants of health, there was a study done that asked the question, what makes people sick? And 50% of it is related to your life, your income, early childhood development, disabilities, education, gender, a social safety network, employment, race, Aboriginal status, safe and nutritious food, housing, and belonging to a community. So 50% of it is actually not your health care. So that's really a large number, and it is really what our summit is about. It's about how do we deal with that 50% of issues that make people sick that are not just directly about drugs. And at the summit, we will talk a great deal about what are some of those issues and how could we help to ameliorate them. Your health outcome is impacted by your health care. So you need to have access to healthcare systems. And as we know, there are a lot of wait times in healthcare systems. 15% is based on your biology and genetics, and 10% is based on your environment, such as air quality and civic infrastructures. So it's very interesting to see what are the great enablers, the greatest enablers of good health outcomes and those that impact least. And as I say, we'll talk a lot about this at the summit, and this just gives you a sense of what we're really going to be discussing there, which will be primarily to do with the social determinants of health. If you have any questions, please ask them in the chat, and we'll answer them through email. And I hope that we'll see all of you at the 9th Annual Summit on November 19th to 21st. Thank you.